My name's Nabeel Sheikh. I'm one of the cardiology research fellows and registrars at St George's Hospital. And I work closely with the team at St George's and also with CRI, and am involved in the screening of athletes. I'd like to start by thanking CRI for inviting me to give this talk today. You guys have got a great 2 days ahead of you, so I hope you enjoy it all. And I'm going to get things started by talking about athletes with ECG changes and looking beyond T-wave inversion. I've got no disclosures to make. So before I start, just to set out some aims and objectives for my talk. The first one is to get people to understand the rationale behind ECG screening and some of the potential issues that we can encounter. The second is to recognize the prevalence and significance of abnormal patterns using current guidelines in athletes. Thirdly, to understand the impact of current ECG guidelines in athletes and the burden of false positive results that this can create. And finally, to recognize the positive impact that refining ECG criteria can have in terms of this issue. So, just to set the context, I think everyone in the room would agree that athletes are widely regarded by society as the epitome of health. Indeed, anyone who watched the Olympic Games last year will be testament to the amazing achievements that these guys can rise to. And it's because of this that athletes are probably regarded as the least likely to undergo a sudden cardiac death. However, unfortunately, sudden cardiac death in sport does occur, and the vast majority of cases are due to inherited or congenital conditions which, although silent, nevertheless can provide the trigger for a fatal ventricular arrhythmia during exercise. And it's because of this that a growing number of sporting organisations and scientific bodies throughout the world now recommend pre-participation screening in an attempt to identify those athletes who may harbour one of these conditions and now therefore at risk. Indeed, if we look at the Italian data and the impact of introducing a screening programme, we find that this is associated with almost a 90% reduction in the incidence of sudden cardiac death in athletes. And it's primarily because of this that the European Society of Cardiology now recommends routine ECG-based screening of all young competitive athletes. So, up till now, this all sounds very straightforward, until we realise that cardiac adaptation to exercise, otherwise known as the athlete's heart, is associated with a number of electrical modifications which can be manifest on the surface ECG, as well as structural changes which we can see on echocardiography. Now, these reflect functional changes which are fundamental to generating and maintaining increased cardiac outputs for prolonged periods of time. And although the vast majority fall within the remit of physiology, a small but significant number of changes overlap with those that are observed in several cardiac conditions that are implicated in sports-related sudden cardiac death. And therefore, the potential rises for false positive results. Now, in an attempt to tackle this situation, the European Society of Cardiology updated their guidelines in 2010 to try and further account for changes which they felt were physiological. And we're primarily talking about isolated voltage criteria for left ventricular hypertrophy here. The 2010 document divided athletes' changes into Group 1, or common training-related changes which do not warrant further investigation, and these include sinus bradycardia and first-degree AV block. And Group 2, or uncommon changes which they felt require further investigation, and these include things such as T-wave inversion, atrial enlargement, and axis deviation. And indeed, it has been shown that the new ESC 2010 guidelines do reduce the false positive rate. However, there's still a number of issues that arise with these guidelines. For a start, the false positive rate is not negligible. Studies have consistently demonstrated false positive rates between 10 and 20%, which for most people are still unacceptably high. Secondly, the question does arise as to whether the data derived for these guidelines are based on a truly athletic population. For example, this was one of the studies from Italy that the guidelines were derived from in over 32,500 Caucasian individuals. And if you read the paper, you find that the cohort that was used was an unselected cohort comprised of individuals entering athletic activities for the first time, or amateur athletes. And also the reported prevalence of sinus bradycardia was only 1%, and this is a bit odd given that other studies have reported a 50 to 60% in other athlete groups. So it questioned whether this group was truly elite. And finally, what about ethnicity? In a globalized world and with increasing globalization of pre-participation evaluation, this issue simply cannot be ignored anymore. In particular, Afro-Caribbean athletes are forming an ever-increasing population of sports people competing at the highest levels. And we know from a number of studies now, including this one by my colleague, Michael Papadakis, that Afro-Caribbean athletes exhibit more ECG changes in response to exercise than Caucasians. This is some data from his study, and you can see that across the board, Afro-Caribbean athletes exhibit more ECG changes compared to white athletes. In particular, the prevalence of repolarization anomalies, such as T-wave inversions, are found in almost a quarter of black athletes. And the vast majority of these are confined in this pattern to the anterior lead, so V1 to V4, and preceded by convex ST segment elevation. However, if we go on to look at the significance of these changes and what they actually mean, our experience has been that after long-term follow-up and comprehensive evaluation of Afro-Caribbean athletes with this particular pattern, we've never uncovered any evidence of a cardiomyopathy. On the other hand, when T-wave inversions extend into the lateral or inferior leads, then in a small number of athletes, both black and white athletes, this has been associated with a cardiomyopathy. So taking these findings into account, this year we had the publication of a new set of criteria, the so-called Seattle criteria, which some of you may have heard of. And the main differences between this and the ESE 2010 criteria were that, for the first time, they did recognize that T-wave inversion in V1 to V4 in black athletes may be a physiological finding. And there are also some other changes. For example, they reclassified the QT interval. So they increased the cutoff to 470 in males and 480 in females, and I'll come back to this point later on. And indeed, a recent study published this year has shown that compared to the ESE 2010 guidelines, the Seattle criteria do result in a reduction in the false positive rate with an obvious associated increase in specificity. However, once again, several issues still remain with the Seattle criteria. For a start, they've only ever been tested in Caucasian athletes. And secondly, if I take you back to this bar chart, what about all these other changes? Look at the prevalence of RVH in black athletes, the prevalence of atrial enlargement, axis deviation. These findings are not insignificant in this cohort. And if you look closely at the chart, you'll also find that these changes are important not only in black athletes, but also in Caucasian athletes. So the question arises whether these changes actually represent pathology, or are they also physiological training-related patterns? So given all this data and these facts, since 2010, we've basically performed a critical appraisal of our own screening practice. And we've asked ourselves three main questions. The first one is, what is the clinical significance of these ECG patterns other than T-wave inversions? What do they mean? Secondly, what impact do current ECG screening criteria have, particularly in Afro-Caribbean athletes? And finally, can we do something about this? Can we refine ECG criteria in order to try and reduce the false positive rate whilst maintaining sensitivity? And I'll take you through these in turn. So the first thing we looked at were abnormal ECG patterns beyond T-wave inversions and what these meant. And specifically, we wanted to find out what's the significance of right ventricular hypertrophy, atrial enlargement, and axis deviation when found in isolation on an athlete's ECG. So you might ask yourself, well, what do I mean by isolated? Well, isolated means that one of these ECG abnormalities are found on their own without any other ECG changes apart from training-related changes. And we find that the vast majority of athletes, when we find these changes, they are in isolation. So this would be an example. This is an example of isolated right atrial enlargement where there's just enlarged P wave in lead 2 and no other changes. So, bearing this in mind, we first of all looked at whether axis deviation or atrial enlargement should be categorized as abnormal in young athletes. And this led to this publication recently in the European Heart Journal by my colleague, Dr. Gatti. Just to take you through some definitions, our definition of left axis was a frontal cardiac axis of less than or equal to minus 30 degrees, right axis greater than 115. Right atrial enlargement on the ECG was defined as a P wave of greater than or equal to 0.25 millivolts in leads 2, 3, or AVF. And left atrial enlargement, a biphasic or predominantly negative P wave in V1 or V2 greater than minus 0.1 millivolts and 40 milliseconds in duration. So, in this study, we looked at the prevalence of isolated axis deviation and atrial enlargement in just over 2,500 young elite athletes, nearly 10,000 asymptomatic non-athletic controls, and these individuals were evaluated with ECG and echocardiography. In addition, we wanted to find out the prevalence of isolated axis deviation and atrial enlargement in a group of patients with hypertrophic cardiomyopathy. And this consisted of 140 sedentary individuals, but also 31 young asymptomatic athletes with hypertrophic cardiomyopathy. In other words, individuals that you would expect to come across during pre-participation evaluation. And these are the results. So you can see from this pie chart, which is a breakdown of the ECG findings, that the vast majority of athletes did have either a normal ECG or group 1 training-related changes. But group 2 changes did make a significant proportion of the abnormalities, so 13% of all ECG findings. If we take a closer look at this and look at the breakdown of group 2 changes, we find that even though T-wave inversion was still the most prevalent, if we take a look at axis deviation, atrial enlargement collectively, these form nearly half of the group 2 changes, and overall 5.5% of ECG changes in total. And these were always found, again, in isolation. So we then went on to look at what do these changes in isolation mean. So in terms of the athletes, we had 139 athletes with isolated axis deviation and atrial enlargement. And on echocardiography, none of them exhibited any evidence of a cardiomyopathy. The prevalence of congenital and valvular defects was the same in this group compared to those with group 1 or normal ECG changes. And in addition, all individuals exhibited normal systolic and diastolic function. And they also appeared to have a larger LV and LA dimension, in addition to a lot of exercise being an independent predictor, which suggested that perhaps these patterns may have a physiological basis. So moving on to the controls, group 2 changes were found in 7.6%, and a combination of axis deviation in isolation and atrial enlargement in total were found in 4.4% versus 5.5% in athletes, which is significantly lower. Again, if we took these individuals with either isolated axis deviation or isolated atrial enlargement, we found that even in the sedentary control group, there was no evidence of a cardiomyopathy. And again, the prevalence of congenital and valvular defects was the same between those who had a normal ECG. And finally, we looked at the prevalence in our HCM cohort. And isolated axis deviation and isolated atrial enlargement were found in only 9 patients. 6 had a very mild phenotype with a wall thickness of less than 16, and all had symptoms of family history. And you could argue that you would expect to pick these people up during pre-participation screening anyway because of this fact. And importantly, at least in this cohort, none of the athletes with HCM had these changes in isolation, so they always had other abnormal findings in addition, predominantly T-wave inversion. So the conclusion from this study was that axis deviation or atrial enlargement in isolation rarely represents pathology in young athletes, is an uncommon finding in HCM patients, and at least in this cohort, is absent in athletes with HCM, which suggests that removal of these patterns would not miss any pathology if we remove these patterns as abnormal in pre-participation screening criteria. So, having said that, we then went on to look at the clinical significance of electrocardiographic right ventricular hypertrophy. As you can remember, this also made a big proportion of positive ECGs in our athlete cohorts. And this led to another publication in the European Heart Journal by my colleague, Dr. Zaidi. Just to define voltage criteria for right ventricular hypertrophy, the definition used by most criteria are the Sokolow-Leon voltage criteria, which is the sum of the R and the S wave in V5 or V6, whichever is bigger, being greater than or equal to 10 millimeters. So bearing that in mind, we examined ECG RVH in just over 620 athletes, nearly 250 sedentary controls, who were all assessed with ECG and echocardiography. We also wanted to find out whether ECG RVH was a marker of other right ventricular pathology. So we also looked at patients with RV pathology, and this group consisted of just under 70 patients with ARVC and 30 patients with pulmonary hypertension. And we selected asymptomatic mild cases in order to, again, simulate those people that we would encounter in day-to-day screening practice. And here are the results. So RVH and ECG was common in athletes than controls, as you would expect, but did not correlate with RVH on echocardiography, and did not predict the presence of a cardiomyopathy, a congenital defect, or valvular abnormalities. In terms of the patient cohorts, in the ARVC patients, only one individual exhibited RVH on ECG, and this was found in combination with a very abnormal cardiac axis, so in other words, not in isolation. And again, in the pulmonary hypertension cohort, RVH on ECG was found in 10 individuals, but again, always in combination with other ECG findings. So the conclusion from this study was that, again, in asymptomatic athletes, isolated RVH on the ECG is not associated with cardiac pathology, is a likely benign and physiological change, and in the disease cohorts, no case would have been missed if Sokolow-Leon RVH was removed as an abnormality from current screening criteria. So, with all this data in mind, we then performed another study to go on to look at the impact, first of all, of current ECG criteria in screening a large cohort of athletes, and also what the impact of refining criteria would be given the data that I've just presented. And the aims of this study were, as I said, first of all, to assess the impact of the ESC 2010 and Seattle criteria in a large cohort of elite black and white athletes. Secondly, to assess the performance of a proposed set of refined criteria in both black and white athletes, and the refined criteria derived from these studies that I've just shown to you, and I'll go into this in more detail in a second. And finally, we wanted to assess what the performance of all three criteria would be in identifying athletes with HCM, which is a leading differential diagnosis when some of these changes are found, and is the leading cause of death in young athletes. So just to talk a bit about our refined criteria. This consisted of a group of what we felt were physiological, normal training-related variants, as with the ESC criteria. These obviously included sinus bradycardia, first-degree heart block, and voltage criteria for left ventricular hypertrophy. And in addition, we had a set of criteria which we felt were definitely abnormal and warranted further investigation. And this included ST segment depression, pathological Q waves, and bundled branch block. In addition, we proposed a set of borderline variants. These included atrial enlargement, axis deviation, RVH, and T-wave inversions up to V4 in Afro-Caribbean athletes. And we proposed that if any of these findings were found in isolation in an otherwise asymptomatic athlete with no family history or examination findings, then they should be categorized as normal. On the other hand, if two or more of these findings were present, or if the athlete was symptomatic, then they should be investigated as being abnormal. Just a quick word about the QT interval. In line with the Bethesda guidelines and the recent Seattle criteria, we also increased the cutoff for an abnormal QT interval to 470 in males and 480 milliseconds in females. And we felt that this offered the best compromise between false positive and false negative findings. So moving on to our methodology. So between 1996 and 2012, we evaluated over 5,500 athletes a significant proportion of whom were Afro-Caribbean, so over 1,200. And these individuals went through pre-participation evaluation with history, examination, and 12-lead ECG. And just to point out, our practice during these years of ECG interpretation was very similar to the current ESE 2010 guidelines. So if any one of history, examination, or 12-lead ECG were positive, or in some cases, as dictated by the club's policy, because some athletes undergo echocardiography regardless of examination findings or ECG findings, then a certain number of individuals went on to have echocardiography and other investigations as deemed necessary. And this cohort consisted of just over 3,200 athletes. And what we then did was, we went back and looked at all the ECGs and applied the ESE 2010, Seattle, and refined criteria to our entire cohort of athletes to determine the number of positive ECGs we would get. And we did the same for our cohort. We did the same for a cohort of 103 athletes with hypertrophic cardiomyopathy, again to see what the performance of these criteria were in athletes with hypertrophic cardiomyopathy. I just want to talk a little bit more about this because this is something unique and hadn't ever been done before. Our cohort consisted of 103 athletes with HCM who are young and asymptomatic. In other words, there would be the same kind of individuals that you would expect to come across during pre-participation evaluation. In fact, the majority indeed were diagnosed with pre-participation evaluation, and we used the initial presenting ECG for analysis. And we felt that this enabled very valid comparisons with like-to-like patients with our athlete cohort. So, moving on to our results, we've got the three different criteria here, and I'll start with talking through what we found in white athletes. And the ESE recommendations produced a positive ECG in 16.2% of white athletes. That's nearly 1 in 5. The Seattle criteria reduced this down to 8.5%, but the refined criteria reduced this even further to just 5.3%. And this represents a 66% reduction compared to the current ESE guidelines. Moving on to black athletes, the ESE recommendations have huge implications for this cohort. Almost 1 in 2 Afro-Caribbean athletes had a positive ECG requiring further investigation. And even though the Seattle criteria improved on this, still almost a quarter of Afro-Caribbean athletes would have required further investigation. But the refined criteria brought this way down to 11.5%. And if you pause and look at this data for a minute, you'll find that this value is actually less than the value of positive ECGs that we currently see in white athletes using the ESE 2010 criteria. And finally, all three criteria were extremely good at identifying patients with hypertrophic cardiomyopathy, and I'll come back to this point again later. So you're probably asking, well, where did the refined criteria have an impact? And I'll show you that now. So the red colours represent black athletes, the blue white athletes, with the lighter colours, the ESE guidelines, and the darker colours, the refined criteria. And first of all, if we look at black athletes and T-wave inversions, obviously this is where the biggest impact was had. And we wouldn't expect it to have an impact in white athletes because we didn't change the criteria. But furthermore, big impacts were also had by removing isolated RVH as an abnormality, isolated axis deviation as an abnormality, and reclassifying the definition of an abnormal QT interval in athletes. Axis deviation also had an impact. And importantly, all these criteria had an impact not only in black athletes, but also in white athletes, where a significant reduction in the number of positive ECGs was seen. So at this point, you're probably wondering, well, this is all well and good. Obviously, if you're going to remove things as abnormalities, the number of positive ECGs is bound to decrease. The question you're probably asking is, did you miss any pathology? And this is what we went to look at next. So as I mentioned, just over 5,500 athletes underwent screening. If the initial screening was positive, or as dictated by the club's policy, some had an echocardiogram with further investigations as required. And out of our entire cohort, we identified 40 athletes with pathology. Now, there's a lot of information on this slide, and I don't expect you to take it all in, but the main things I want you to concentrate on are that minor congenital and valvular abnormalities are denoted in green, and sinister cardiac pathology in red. And I want you to concentrate just on the athletes that were identified on ECG alone. So if we took a look at these individuals, we found that they would have been identified by any of the three criteria. In other words, the refined criteria did not miss any athlete that would have been picked up by the Seattle and the ESC 2010 criteria. We then went on to try and calculate the sensitivity and specificity of all three criteria. So in terms of our methodology, I mentioned that a certain proportion of athletes would have had an echocardiogram as dictated by their club's policy as standard, so regardless of whether the history examination or ECG was positive. And this group consisted of just under 3,100 athletes. And this group actually also contained all the athletes we had diagnosed with pathology. So we used this cohort to calculate the sensitivity and specificity of all three criteria. So starting with black athletes, if we first of all looked at sensitivity, this remained 70% with all three criteria in black athletes and was 60% in white athletes. Again, no change between the criteria, and I'll come back to this point again a bit later. However, in terms of specificity, this was pretty low with the ESC criteria in black athletes, only 40.3. There was an improvement to 76% with the Seattle criteria, but it improved to 84.2% with our refined criteria. And additionally, even in white athletes, even though the ESC criteria weren't bad, a specificity of 73.8%, the Seattle criteria improved this to just below 90%, but our refined criteria improved this to just under 95%, which is a dramatic improvement. And obviously, in accordance with this, we found a reduction in the false positive rate in black athletes from just under 60% using the ESC criteria to just under 16% with our refined criteria, and in white athletes from 26.2% down to just under 6%. So let me just take you back to this slide, and you're probably wondering, well, actually, look at the sensitivity here. It's actually not that great. It's pretty low. But if you look at this slide, you'll find that some athletes were diagnosed with minor congenital and valvular abnormalities, such as mitral valve prolapse and bicuspid aortic valve with a normal gradient. And you wouldn't necessarily expect history examination and ECG to pick up these conditions, nor would you expect these conditions to be associated with sudden cardiac death. So what we then did was actually recalculate our sensitivity for what we felt was sinister cardiac pathology, so all the conditions shown in red. And if we did this, we found that the sensitivity using our refined criteria in the overall screening process improved dramatically to 100% in black athletes and 92.9% in white athletes without a significant compromise in specificity or the false positive rate. And finally, take you back to this slide, and I mentioned that even though all three criteria were good at picking up individuals with hypertrophic cardiomyopathy, a couple of individuals failed to be identified. And you're probably asking, what's their demographics? So these are the two individuals that all three criteria did not identify. And I think you'll agree that both of them had a mild phenotype, so it could be argued that their risk with sport is less, although that's not sort of based on any scientific proof, but it could be envisaged that that's the case. And in addition, one had a positive family history, so again, you might expect to pick them up during screening. So, in conclusion, ladies and gentlemen, I think I've demonstrated that ECG patterns apart from T-wave inversions are common in athletes, but that the majority are found in isolation and do not represent significant cardiac pathology. In addition, current criteria have significant implications for black athletes, with almost 1 in 2 requiring further investigations, but also have significant impact in white athletes, with almost 1 in 5 individuals requiring further investigation. And despite recent modifications with the Seattle criteria, there still remains a relatively high number of athletes which would fail the initial pre-participation screening based just on ECG. And this is obviously much more for black athletes. However, modification of our criteria can improve specificity whilst maintaining sensitivity, with a number of positive ECGs right down to 5% in white athletes and to 11.5% in Afro-Caribbean athletes. So given that no screening strategy based just on history and examination has ever been found to reduce the incidence of sudden death in athletes, I think the best alternative is therefore to strive towards refinement of our current ECG criteria with the aim of improving specificity whilst maintaining sensitivity. And indeed, I think our data shows that this can be done. This should be coupled with appropriate training of physicians in the correct interpretation of an athlete's ECG, and ethnicity and training-related patterns beyond T-wave inversions must be taken into account. So I'm going to end there. Thanks for your attention, and I'll be happy to take any questions.